Okay. All right. Thank you, everyone, for coming to the CHEP seminar this week. We're lucky to have Barton Willage here from Cornell University. He's a PhD candidate in the economics program. In his young career, he's already published in the top health and medical journals. He has an article in Journal of Health Economics and in JAMA. Can I say?
Yes.
Okay. All right. Barton's accepted a position in the economics department at Louisiana State University, so very excited for him. And today he's going to be presenting on ex-ante moral hazard in health insurance, looking at the effects of the ACA on risky sex. Barton, thanks for being here.
Thank you. And thank you all for coming. For those of you who are thinking about or currently in PhD programs, this is my job market talk. It still has a slide in it that is usually in job market talks, but not in your average seminar. So I will be talking about the unintended consequences of health insurance and how it pertains to risky sex. And I'll be talking about the ACA and what we know about the effects of health insurance today. So this is my brief bio that is in here from my job market talk. I was told this is a good thing to have in a job market talk and also helpful for people I haven't met with today. So I am a health economist, and I also do a lot of work in public economics. I'm particularly interested in how public policy affects people's health behaviors and health outcomes. I do applied micro, focusing on causal inference, not so much structural modeling and things like that. And some other projects that I'm working on, one is in the Journal of Health Economics, and this is on the effects of weight on mental health. Drew heavily from your work for that paper. And I'm also interested in the effects of higher education on people's health. I think that there's a lot of interesting complementarities there. And then with a collaboration with several other researchers looking at the effect of WIC, which is sort of like food stamps, but for women, infants, and children, and how that affects diet and health. So back to this particular topic, I'm going to talk about insurance and how that can be good and how that can be bad. So insurance can be good. Protects against shocks, lets us smooth our consumption over our life course, but it can also have unintended consequences. And these are known as moral hazard, and that language is taken from the insurance industry. It's causes a lot of miscommunication with other disciplines. So one kind that I'm going to be focusing on here is ex-ante moral hazard, and this is basically the fact that insurance decreases the implicit cost of engaging in risky behaviors, and so it causes people to demand more risky behaviors. There's not a lot of research on this, though there are some recent papers looking at opioids and how new technology can increase people risky behaviors relating to that drug use. Another kind that receives a lot more attention but is not the focus of this paper is ex-post moral hazard. And this is basically that insurance decreases the out-of-pocket cost for healthcare, so people demand more than socially optimal healthcare. If insurers knew exactly what we would do in the absence of insurance, they would only cover the kind of demand that we would have in that context, but they're not able to get all of that information, so they can't completely stop these kinds of distortions. So why is this a problem? So one is there's a negative externality. If I'm using more and more healthcare, that burden is spread across my entire insurance risk pool, and so if we're in a pool together and I'm going to the doctor all the time, you're paying for me to go to the doctor, and so I'm going to demand too much, and you're going to have to pay for it. Secondly, is that ex-ante moral hazard, this increased demand of risky behavior, causes people to get sick and injured more often, and we maybe want to consider that when we're thinking about the cost-benefit analysis of health insurance expansions. What are these unintended consequences, and how do we measure them? So broadly, in this research, I'm curious, does health insurance cause people to engage in more risky behavior? Is there ex-ante moral hazard in health insurance? Specifically, I'm going to look at the Affordable Care Act, or the ACA, or Obamacare. It's got a lot of names at this point. I'm going to see how one tightly targeted mandate in that law affects prevention in terms of condom sales, STIs, and fertility. And just a brief preview of how I'm going to do that, I'm going to use dose response event studies, basically using a continuous measure of treatment intensity to look at the effect of this policy on those outcomes. Two quick notes about terminology I'm going to use. So when I say risky sex, I'm talking about sex without a condom between a man and a woman. Obviously, there are other kinds of risky sex out there in the world, but given the mandate I'm talking about, this is the relevant population. And then when I say birth control, I'm gonna mean prescription contraception. I'm gonna try to say prescription contraception, but it's a bit of a mouthful. So I might say birth control sometimes. Usually this is hormonal. You can think of oral contraception or the pill, an IUD, a rod inserted in the arm. I'm not talking about condoms. When I'm talking about condoms, I'll say condoms.
So at this last meeting of the Eastern Economic Association, Chuck Portmanch presented some new work he had on the Affordable Care Act, sort of looking at the effects on use of preventative care and on risky behaviors, moral hazard stories. And one of the outcomes he looked at was HIV testing in the BRFIS, and I think found sort of that increases in Medicaid expansion, sort of part of the ACA, increased HIV testing.
Yep.
What was sort of your reaction to that and how it fits into what you're doing?
So one thing is that the mandate I'm looking at is the fact that health insurance has to cover prescription contraception with no out-of-pocket cost. And so this didn't affect the cost for a lot of things like that, especially for the population I'll be looking at, are people in their late 20s. This mandate did actually affect people in their early 20s a little bit in their accessibility to testing, not people in their late 20s. And I do robustness checks with people in their early 30s, and those people were not affected on it. Yep. And I have some evidence about testing on the STIs I'm looking at. So more about moral hazard, because this is not a thing that people talk about so much. So I have a couple of examples in this quote, which I think is interesting. So basically, ex ante moral hazard is the fact that market insurance has on self-protection that increases the actual probability of hazardous events. So basically, market insurance makes us do things that make it more likely that we get sick or injured. That's ex ante moral hazard. So here are some examples. So it's not only health insurance that can have ex ante moral hazard, it's car insurance, it's homeowners insurance as well. So looking at car insurance, the state of the world is, do you have a car accident or not? So that you don't know if that's gonna happen or not, but at some point you'll realize that state of the world. Anything you do before that, any distortion from insurance, that's ex ante moral hazard. So if car insurance makes you drive worse, so if you don't check your blind spot, you speed, you don't use your turn signal, that's ex ante moral hazard. It increases the probability of a hazardous event. Once you do realize the state of the world, so let's say you have a small fender bender, if car insurance makes it more likely that you get that fender bender fixed, that's ex post moral hazard. Basically, car insurance lowered the cost of getting your fender bender fixed, and so now you're more likely to do it. And my particular context is the state of the world is, do you have an STI or not? So anything that health insurance does that increases the probability of having an STI, that's ex ante moral hazard. So if you have more sex without a condom, and that increases your probability of an STI, that's ex ante moral hazard. Once you do have that STI, if you're more likely to get treated because health insurance is gonna pay for it, that's ex post moral hazard. So there's just a couple of examples to help you distinguish ex ante and ex post moral hazard. So about the mechanisms, because this is not the mechanism that we usually think about when we think about ex ante moral hazard. Traditionally, people think about the cross-price effect between prevention and treatment. So basically, if you don't have to face the financial burden of getting treatment, you're more likely to engage in the risky behavior because you don't need to pay in terms of money or burden prevention. What I'm looking at here is a cross-price effect between narrow medical-based forms of prevention and general behavior-based forms of prevention. So basically, the mandate I'm looking at makes birth control free. That means people are more likely to do it. This is technology-based form of prevention for pregnancy. But it doesn't protect against STIs, and so people are now exposed to more STI risk. So one reason I think this doesn't get a lot of attention is this isn't so much a concern in other forms of insurance. The thing that's maybe most relevant is the literature on seatbelts and how seatbelts let people drive more riskily and they started hitting pedestrians. But that didn't expose the driver to more health risk or protect against getting in accidents generally. Another thing is that it required this technology advancement in medicine. So when the ex ante literature, moral hazard literature started in the late 60s and early 70s, prescription contraception wasn't very widespread, so people didn't have to worry about this kind of trade-off happening. But now that we're in a new, more technologically advanced society, this is a concern that we should have. And also importantly, most empirical analyses can't differentiate these two mechanisms. If I just showed you that there was an insurance expansion and people were engaging more riskily, you don't know it's because they have access to this new technology or if it's because they weren't worried about the cost of treatment in the future. So why do we care about the effect of health insurance on risky behaviors and the consequences of those risky behaviors? This is one really nice thing about health insurance is we spend so much money on healthcare, even small disturbances from the optimal allocation can have really meaningful effects. So we spend $3 trillion on healthcare in 2014. I think that's something like 17% of GDP. It's a lot of money. So even if you mess with that a little bit, that can be really meaningful. Also, moral hazard results in distortions from optimal choices. This can have meaningful effects on social welfare. So one interesting fact is that Finkelstein finds that insurance is one of the major drivers of the increase in healthcare spending we've seen over the last 50 years. And so really these distortions from health insurance, both in terms of ex ante and ex post moral hazard, are having really meaningful consequences. Another thing to think about in terms of ex ante moral hazard is that it's really hard to detect. One, insurance is very endogenous, so people who have insurance and don't have insurance are very different. You can't just compare their outcomes and say, this is the effect of insurance. Complicating that fact is that a lot of the health behaviors we care about, like smoking and weight, take a really long time to manifest in health shocks. So if I'm smoking today, I'm not going to get cancer for 20 or 30 years. So it's not my current health insurance status that may be distorting my choices, but my expectations in the future. So we sort of need to look at these more quick acting risky behaviors. So something like drug overdoses or risky sex. The outcomes I'm looking at are also very economically important: fertility and STIs. So we spend about $12 billion on unintended pregnancies just with public money. So that's a somewhat narrow subset of pregnancies, and we're still spending billions of dollars on them every year. Though maybe not quite as economically important, STIs are becoming increasingly important because they're becoming resistant to antibiotics. So I just read an article about the first case of like super gonorrhea, that they gave him all the antibiotics they could, and then he still has gonorrhea. Gonorrhea can have important comorbidities, so gonorrhea can cause other infections in the body, particularly for women, causing problems with fertility in the future. And so these antibiotic-resistant STIs can have really meaningful health impacts on the people who have them. I remember when I started the project, I was like, STIs, people like gonorrhea and chlamydia, but you go to shot and they're good to go, but it's becoming increasingly untrue. And then it's just sort of a contentious, interesting policy to look at. So birth control, particularly government-mandated birth control, is a very hotly debated topic in this country. There's a Supreme Court case. So I think there's just general interest in what the effect of these policies are. Whether or not that will affect people's view on if they're good policies or not is up for debate, but I think it's important as scientists to know what these mandates do. And so this policy has actually been significantly weakened by the current administration. It's now basically an opt-out policy, so any employer can say I have a moral objection. And so what effect this policy had when it was implemented can give us some suggestive evidence now that it's being weakened and possibly will be terminated in the future. So a preview of the empirical strategy. I'm going to look at this narrowly targeted health insurance expansion. So just at the intensive margin, people who already had health insurance now had a more generous form of benefits in that they didn't have to pay out of pocket for birth control. This really lets me isolate the ex ante moral hazard effect, this distortion on risky behaviors, because there shouldn't be these other effects of insurance, either in terms of testing or in terms of sort of protective effect of insurance. People don't have access to a whole new set of goods. They just have a little bit better access to this one set of goods. I'm going to use the pre-policy insured rate as a measure of treatment intensity, basically looking at the state year level. The more people in a state who have health insurance, the bigger bite this policy has in that state. I'm going to do non-parametric event studies, sort of plotting the correlation between this treatment intensity and the outcomes over time. And then I'm going to put a parametric assumption on there, basically fitting a line to the pre-period and fitting a line to the post-period and testing if those lines are different. I'm going to give you a little taste of the policy, and then I'm going to spend a little more time on the policy in the next few slides. So basically, starting in 2012, insurance had to cover prescription contraception with no out-of-pocket costs. So if you had insurance, birth control basically became free, and I'm talking about at least one form of 18 methods. So when I started, I didn't know there were 18 methods of birth control, so I knew there was oral contraception, I knew that there was IUDs, and I knew there was a rod, but covers sterilization for women, but not men, both surgical and non-surgical, and a number of other prescription contraceptions. And so I'm hypothesizing that this will cause more people to use prescription contraception, and that means that condoms become yet less useful to those people because condoms do two things. They protect against STIs and they protect against unwanted pregnancy. But if you're on prescription contraception, then it only protects against STIs. And so though the cost has stayed the same, the benefit has decreased, and so fewer people will use it. And so basically, I expect this to cause more STIs. Everyone is affected, but I'm going to focus on people in their late 20s. And the reason is that there's a policy in 2010 that affected people in their early 20s and their access to insurance. It's the dependent coverage mandate. Basically, if you're in your early 20s, you can be on your parents' health insurance. And I wanted to make sure that that policy did not contaminate this analysis.
It can for 25-year-olds.
So there's a little bit of contamination with 25-year-olds, and also there's some aging in. So I do a robustness check with people in their early 30s, and so the effects are pretty robust to that.
Is this driven by this is what you can get rates of STIs?
Yeah, so the STI data is only available in these 5-year age bins, and so there's a little bit of contamination there, so I wanted to make sure that it was robust to that.
Is it there? There's no way to get it. I just remember this issue arose when I think Ted Joyce was doing something looking at the effects of parental involvement laws on STIs, right? And one of the things he was arguing is that, so I think a policy found that these laws had an effect on gonorrhea rates. Looked at like 15 to 19-year-olds, and the 18 and 19-year-olds weren't affected.
Right.
So he was, and I know it was maybe it was a subset of states that were affected, but there's no way you can.
There's no good, so it's interesting this about data for people who are new to research is you would think that there's information on stuff and there isn't. So for instance, there's not really good information at the national level on prescription contraception use or condom use. And so I'm constrained to looking at condom sales. And so yeah, it is in these 5-year age bins for disclosure risk. But the good thing is that it has really good coverage that I'll talk about in the data section. But so yeah, I agree that there's this contamination. And so there are some robustness checks and falsification tests to deal with that. One good thing about this policy is at the federal level, so we don't have to worry about policy timing endogeneity. So it's not that states were experiencing really high rates of unintended pregnancy and implemented this policy to counteract that. It's just that every state was affected at the same time and they had different levels of exposure to it based on their pre-policy insured rates. And so I'm going to look at this margin to really isolate the ex-ante moral hazard again, really to reiterate that point. But I'm going to do an extension that if I have time at the end to look at the effect of the extensive margin of health insurance, what happens if people newly get insurance, and I'm going to use that dependent coverage mandate to get at that question if we have time. So this study sits at the intersection of two literatures, the ex-ante moral hazard literature, or how health insurance affects risky behaviors, and then also with the economic causes of people engaging in risky sexual behaviors. So in the moral hazard literature, there's two branches. There's the ex-post moral hazard and there's the ex-ante moral hazard. And the ex-post moral hazard, there's both really clear evidence empirically and compelling theoretical evidence. So in terms of empirics, there's the Rand health insurance experiment and the Oregon health insurance experiment. Basically, people randomly got different generosities of health insurance, and they found that people use more healthcare when they have better health insurance. There's good theory on ex-ante moral hazard. But the empirical evidence is very mixed, and I'm going to talk about that in more detail because that's the most closely related literature. So the most common strategy I've seen in my literature review is people do difference in differences, basically looking at either a state or a group that got exposed to health insurance expansion and compared them to a group that does not experience a health insurance expansion. So here in this middle is Medicaid expansion, a very hot topic right now. So Simon and her co-authors look at Medicaid expansion states and states that did not expand Medicaid and see if there's any changes in a whole host of outcomes, including risky behaviors. And they don't find any effect on behaviors like smoking or exercise. And so that they find no evidence, but other studies have found evidence sort of looking at heavy drinking, but not other behaviors, or only for men and only for a subset of behaviors. So it's a real mix. And I think this goes back to my original point, which is these behaviors probably shouldn't be responsive to contemporaneous shocks to their health insurance status because they take so long to result on health shocks. And so if I get health insurance today and I didn't used to have it, why would I start exercising when I don't think I'm going to need cholesterol medicine for another 30 years? So maybe I'm being overly optimistic about my future health. Contrasting to that is the economics of risky sex. So generally people find that risky sex is responsive to changes in the implicit cost of engaging in risky sex, sort of what you were talking about earlier. What happens if we make it harder for teens to get an abortion because they have to tell their parents? Do we see effects on evidence of risky sex. So if you make it harder for teens to have abortions, they have fewer cases of gonorrhea. One shortcoming generally in this literature is they can't actually look at the risky behavior themselves. They don't see evidence on contraception or condoms. So this is one area I'm going to contribute using proprietary data on condom sales, looking at condom sales in each state over time. So sort of teasing the contribution. The main one is empirical evidence of ex ante moral hazard in the context of risky sex. And as I've mentioned, this is generally hard to find due to both the endogeneity and the timing issue. And so I'm going to overcome those obstacles by focusing on this tightly targeted zero cost sharing mandate, and then looking at a behavior that should be responsive to contemporaneous shocks in health insurance, risky sex. There's also an important policy analysis exercise looking at the effect of this mandate in the ACA and providing suggestive evidence on recent and current proposals to roll back this mandate. What I'm not going to do is address the political or moral issues that are involved. I'm not going to try to say who's right or who's wrong. I'm not doing a structural analysis to do welfare implications. I'm going to use economic theory to say what I think this policy should do, and use econometric methods to say what this policy did do. So a preview of what it did do is I find evidence of ex ante moral hazard from health insurance. I find that people bought fewer condoms due to this policy and experienced, due to that, more STIs. Not ex ante moral hazard, but an important outcome to analyze is I find that this policy, easier access to birth control, does reduce births. And then in the extension, if I have time, I'll show you that the protective effect of insurance more than makes up for this increase in risky behavior. Basically, if all your sexual partners are getting their STIs treated because now they have health insurance, then you experience fewer cases of STIs. So a little bit about this policy. So this is a quote from the Department of Health and Human Services that says, starting in August 2012, contraception has to be covered with no cost sharing. So in layman's terms, birth control is free for people with health insurance. And so that's what it says down here. No deductible, so you don't have to pay through your deductible. You don't have to pay any co-insurance. You don't have to pay any copay. You go get your first pill for free. You can get IUD inserted for free. It's completely free for insured women. And so what do we know already about this policy? So one thing we know is that it did decrease the out-of-pocket cost for prescription contraception for people. So basically, at this point, the point 50% point increase in women who are paying zero out-of-pocket. So there are still some uninsured people and people with grandfathered plans who still have to pay, but there's a big increase in the people who had to pay zero. And as we know from behavioral economics, things that are free make us more attracted to them than would be implied from traditional rational choice theory. So we can expect, and as I'll talk down here, people to start using more prescription contraception. But how big was the effect on the price? So the median person actually didn't have a huge decrease. So an IUD went from costing $20 to $0. So the median person actually didn't have a huge effect on theirs, but on the right tail, it had a really big effect. So for the 90th percentile, it went from $844 down to $15. So for a really meaningful number of women, IUDs became much more affordable. So down here, we'll see that there was a 2.3 percentage points increase in the take-up of prescription contraception. And this is from a study using a large sample of women with employer-sponsored insurance in the Midwest. And it is disproportionately these long-acting forms of prescription contraception that they took up. I think this is because an IUD has a really low long-term cost. Once it's implanted, it costs zero for many, many years. But the upfront cost can be very expensive. So if you had to pay out of pocket with no insurance, it could be $1,000. And so this became had a bigger, basically, effect on the short-term price for this. And I think one good thing, personally, I think a good thing about that is that these forms of prescription contraception are more effective than things like oral contraception, which have lower burdens to them, but they cost more over the long run. So I talked about this a little bit, but just to reiterate about what I think this policy is going to do. So one, this policy lowers the out-of-pocket cost for prescription contraception. People are going to start using more prescription contraception. There's empirical evidence of that. Now that people are on birth control at a higher rate, for some of those people, they're going to stop using condoms because some people at least don't like using condoms when they have sex. There's actually empirical evidence that people will pay extra to a prostitute not to use a condom. And so those people may stop using condoms, and that's going to expose them to more STIs. However, this access to prescription contraception is going to lower the unintended and pregnancy rate. So in summary, condom sales are going to go down. I'll empirically be able to test that. Births will go down, and STIs will increase. So what data do you use? So I'm looking at the state year level, and that's because that is the level of treatment intensity. And so the treatment level, the measure of treatment intensity is the insured rate for people in their late 20s, measured right before this policy went into effect. I used the behavioral risk factor surveillance system data for this. There's a large data set. It's representative at the state level, so that's really nice. And it has enough people in this age group in these years to get accurate measures of insured rates for this group. I'm going to look at condom sales. So I'm going to use the Nielsen retail scanner data. If you're not familiar with this, it's pretty great in a lot of ways. So one is that it's administrative data. It's not self-reported, so I don't have to worry about some guy being like, I bought 100 million condoms. It's like, I know exactly how many condoms were sold in these stores during this time. The one downside is that it's not age specific. So I'm going to have to look at the full effect of this policy across the full age range. For births, I use the National Vital Statistics. This is basically every birth in the United States has information on how old the mother was, and so I can look at this age group. And then for the STIs, there's a CDC atlas. Basically, the STIs I look at, which are primarily chlamydia and gonorrhea, are what are known as reportable diagnoses. So if a doctor or a lab detects a case of one of these STIs, they report it to their local health department, and then that information works its way up to the CDC, and so it's basically all diagnoses of these STIs. So the rationale for the treatment measure, which is the pre-policy insured rate. So basically, this mandate only affects people who are insured. So if a state had no insured people, this policy can't really do anything in that state. But if it had close to 100% insured rate, this policy could have a really big bite on people's behavior. It's sort of just the intuition of why this is my measure of treatment intensity. So there's been a lot of slides with words on them. So here's a picture to break it up a little bit. So this is a heat map of the treatment intensity over time. And as you might expect, the insured rate in the Northeast and the upper Midwest is higher, and the insured rate in the South is lower. This sort of reflects general socioeconomic demographics in those regions. But importantly, it is spread pretty much all over the United States, and so it's not just one region that's treated and another that's not. So just to get a sense of where people are highly treated and lowly treated. So what method am I going to use? So first I'm going to do event studies. If you do applied micro, then you're probably familiar with this, but I'll walk through it a little bit. But these are non-parametric and over time, so they're still parametrically estimated, but they don't make any assumptions about the pre-trends and the post-trends. So you'll be able to see any structural change that happens in the treatment year. And then I'm going to apply some parametric assumptions to that. So I'm going to do that for a few reasons. So one is that event studies don't have very clear interpretations of the coefficients, and so it's nice to put some parameterization on there so it's more clear what the estimates mean. I'm also going to get some more statistical power and going to discuss the identification assumptions more clearly.
Is there, I know the BRFIS, it's tough to get the county level information. Is that sort of the main reason, or is the STI not information? You can get some of this. I'm just curious of whether you were able to think about sort of exploiting any within the state by.
So the one reason is that if you want to look at a smaller geography, you can't get the demographics for the outcomes. So you could look at the total number, but you want to be able to look just at this age group. And then the other one is the sample size in the BRFIS would be pretty small at the county level. And so I guess it would technically be unbiased, but it would be a very noisy estimate of the insured rate. And so this is going to let me estimate both an immediate effect in the treatment year and any dissemination effect over time. And so why would we expect either or both of these? So one, if you know that this policy is coming, you know you're going to be able to get birth control in 2012, then maybe as soon as that policy turns on, a person goes to their doctor and they're like, I want birth control, and they distort their behaviors. But I think that there's a lot of reason to think that people were still learning. So maybe a person found out from a friend that now their birth control is free, and they're like, now I can afford to go get birth control. So there can be this dissemination effect from learning. And there's also just a natural compounding effect of STI. So if person A has sex with person B, and now person A is engaging in risky sex, person B is more likely to contract the STI, and person B's future sexual partners, C, D, and E, are now at increased risk. So there's sort of like a fractal effect going on over time. Primarily, I'll find this a dissemination effect. I won't find large jumps in the treatment year. I'll find mostly changes in the slope, just to give you a preview of what's coming. And one good thing about this empirical strategy is that it lets me account for any pre-trend in the event study. So since I'm basically controlling for the pre-trend by fitting the pre-period line, I don't have to worry about just a continuation of trends driving my results. So now to go over in more detail, the event study analysis. So this is the standard event study analysis estimating equation. I have state and year fixed effects down here and a set of controls that I'll tell you about in a second. But most importantly are these interactions between the treatment intensity and these dummy years. And I've omitted the year before the policy, 2011. So basically the beta t for 2011 is going to be mechanically 0. And the other beta t's will basically be the correlation between the treatment intensity and the outcomes in year t adjusted for the correlation in 2011. So basically I'm going to plot out these beta t's and we'll be able to see if anything changes in 2012. This is estimating equation for the parametric analysis. This is a less familiar estimating equation, so I'm going to talk about this method in greater detail. But basically I'm going to fit a line with this pre-period here. So this is the intercept for the pre-period and the slope for the pre-period with time centered at 2012. And then this is the jump that happens. So this is a dummy for being after 2012. This is the jump in the intercept that happens in the treatment year. And this is the change in slope that happens in the treatment year. Here are the interpretations of these coefficients of interest. So beta 2 is a 1 percentage point increase in the treatment intensity results in a beta 2% one-time jump in the outcome. And beta 3 is a 1 percentage point increase in the treatment intensity results in a slope change of beta 3%. So how exactly does this work? Here's a nice visual representation. This isn't real data, this is a stylized graph. But down here on the x-axis we have time, and here we have the log outcome. As you can see, as I mentioned, this point is mechanically 0. So these dots are the beta t's from the event study, and they map out over time, and as you can see any change in the slope and any change in the intercept, but you don't really have a good sense of if those are meaningful and if they're statistically significant. So what I do is I fit this line using this part of the estimating equation, and then I estimate how this line changes in slope and jumps here. So those are the beta 2 and beta 3 I mentioned. So what's the identifying assumption here? It's that in the absence of the treatment, this pre-period line would have continued on this lower dotted line, basically constant relative trends in high and low treated states. So as you maybe noticed, that has some similarities and some differences with difference in differences, which is a sentence that I always get a kick out of saying. So let me talk to you about the similarities and the differences. So similarities. One, I'm going to leverage some differential exposure to treatment, often binary in the most traditional difference in difference, but in this case, a continuous measure of treatment. I'm going to compare the pre-period to the post-period in high and low treated states. So it's again like difference in difference. In fact, a difference in difference is a special case of this. With a flat pre and post line, you would just end up with a difference in difference estimate in that case. Both share this assumption that nothing else happened in that time period, so no contemporaneous shock that differentially affects high and low treated states. But what are the differences? So one is I'm going to estimate both a change in slope and a change in intercept, whereas in a difference in difference, you would just estimate the jump. And I have a less strict identifying assumption that lets me apply this method to more context. And so one thing to keep in mind is that a lot of event studies reverse the trend. So I think, so they were like monotonically decreasing and now start increasing. I think that's going to add some credibility to the method that something actually was happening in these time periods. So some additional information, I told you I had some controls, so now I'll tell you what they are. I have unemployment rate, both for the total state and the age-specific population, the population size, again for the total and age-specific, income per capita, and regulations that may be related to these outcomes. So things like state-related mandates for dependent coverage or weaker zero cost sharing mandates, as well as mandates that relate to abortion, as we've already talked about. So these can have meaningful effects possibly on STIs. So I want to control for all of those things as well. As I've mentioned, I'm looking at people in their late 20s, and that's to sort of stay away as much as possible from the dependent coverage mandate. But there are these 25-year-olds who are grouped into this older group who are affected by the dependent coverage mandate. So I want to look at these people in their early 30s as a robustness check. As I mentioned, the effects on STIs are robust, but the effects on fertility are weaker. I think that's likely due to just aging, decreasing the probability of pregnancy at each age. And then also, as I've mentioned, condom sales are for all age groups, so I won't be able to look only at people in their late 20s. So what I'm going to do is start that analysis in 2010, and I'll talk about what other robustness I can do with that data. I'm clustering at the state level, and I'm weighting by the 2011 age-specific population. So basically, how many people in their late 20s in each state. So now the results, I'm going to review what my hypotheses were and preview my results. So I predicted basically the condom sales and births would go down, and I do find that, and I predicted that STIs would go up, and I do find that, and that's basically due to this cross-price elasticity, basically people substituting from condoms to prescription contraception. So here's the data, here's the results for long condoms. So up here are going to be the predictions in case you forgot what they were, but here I find no real effect on the intercept, but a decrease in slope of basically 0.1. And so what does that mean in terms of like overall effects on condoms? Basically, I find that this policy, if you increased the treatment by a standard deviation, 3 years after this policy went in effect, you would see 10 million fewer condoms sold. And so that, I would say, is a pretty meaningful number of condoms sold. But just to remember that this is across the whole age distribution, so this policy affects all ages, and this is condom sales for all ages. One thing that I've done that I don't have in my slide deck, but I can talk to you about, is this is the one data I can look at more fine time periods. And so since there's only 2 pre-periods, I have it for each month, and it still looks, it has some cyclicality, but it basically looks flat in this period and then starts sloping very sharply down in the post period.
So the 2 questions I have, and I know that the first you're going to try to rule out with the falsification test, but what are the other main provision changes that we might be worried about that were implemented along with the zero cost sharing? So that's one. And then the second story is the sort of some theoretical kind of interpretation about this, this why we might expect for some of these outcomes sort of a slope change versus a jump.
So, so some of the other provisions were like domestic abuse counseling and for high-risk populations, some increased access to testing. But the high-risk populations are people in their early 20s, so it doesn't apply to this population. But I think that there could maybe be, one concern is that people are just getting tested more, for instance. So you would see more diagnoses without a change in more diagnoses, but without a change in the increased actual prevalence or incidence of the disease. So I have some evidence about testing. It doesn't really look like testing is responsive to this, to either mandate that I look at here. In terms of the slopes, I think, so for instance, condoms, you would maybe expect that to respond most immediately, especially given the large effects that I see on STIs. So one thing is that you could see a larger increase in STIs if people already bought the condoms and they just stopped using them. And so there's like a group of people who aren't getting picked up here that are responsive already. And then, yeah, I mean, in terms of the slope, it just takes time for people to change their behaviors. There's some inertia. So, a man is the primary condom purchaser often, even though a woman is the primary prescription contraceptive purchaser. So one thing I've been thinking about is how does the information move? So especially in a non-monogamous relationship, one person might not know about the changing birth control use of their partners, and it may just take time for both the woman to change her birth control use behavior and then the man to change his condom purchasing behavior. And then I think that the story for the STIs is a little more clear in terms of like the compounding effect. But for this one, I think that there's a lot of information. There's more people who have to change their information changing behavior. So now looking at births. So as I mentioned, I would expect increased access to prescription contraception to decrease births, mostly unintended pregnancies, but I can't disentangle unintended and intended pregnancies. But here you can see in the pre-period, it's pretty flat, a slight downward slope, but kinks down very sharply in the post-period. And so I find that this policy, if you increase the treatment intensity by a standard deviation 3 years afterwards, you would expect about 25,000 fewer pregnancies just amongst people in their late 20s. So that seems like a pretty meaningful effect, especially in terms of the fact that unintended pregnancies are can be quite burdensome to some people. So one, they're expensive, mostly through Medicaid, so we're paying for it. But also it can be a real burden to the woman and her family. She has to invest in this. And so I think that that's a pretty, to me, economically meaningful result. Here's the effect for chlamydia. So If you don't know much about different STIs, chlamydia is the most common STI. It is primarily found amongst heterosexual women, and so this is the main STI we would expect to be affected by this policy. As you can see, it's decreasing monotonically in the pre-period and bottoms out the year before the policy goes into effect, and then jumps and flattens out in the post-period. And so this, I find, caused about 18,000 more cases of chlamydia 3 years after the policy if you increase the treatment intensity by a standard deviation. Here's the event study for gonorrhea. So this is primarily found, but not as frequently as found amongst heterosexual couples. It is significantly less common, but still very common than chlamydia. So it's pretty flat in the period and jumps in the post-period, but it's not statistically significant. And the back of the envelope calculation only results in about 1,300 more STIs. So chlamydia is much more affected by this policy than gonorrhea.
What is that gross increase, 1,300 in a typical state?
So it's national. So if you increase the insured rate nationally by 8%, it would be, and then 3 years after the policy, so like at this time, it would only be a third. So it's like pretty small. So we have a whole half hour left, so I have a lot of time to talk about extensions. So there's a lot of things you would maybe want to do. So if a state doesn't have data for all time periods, or if it has a 0 for any cell, then the log is going to drop that out. And so I balance the panel, and the results are very robust to that. I also wanted to do unweighted regression. So one reason to do this is it lets me see if there's heterogeneous effects. So in the unweighted regressions, I find that the results are smaller and not statistically significant. So that, to me, that says that more populous states are more affected than less populous states, which to me makes a lot of sense because there's more contained, there's a lot more behaviors likely happening within that state than across states. So I'm doing a log linear regression, and so that has some assumptions about the distribution of errors. So I also do a Poisson regression, which has the same basic interpretation, but makes it different for count data, and so the results are robust to that. And then one thing that happened in 2014, which is the reason that I stopped in that time period, is that Medicaid expanded in 2014. But there were some early Medicaid expanders. And so I didn't want them and their correlations with my outcomes and my treatments to contaminate my results. So I do an analysis where I exclude them, and the results are robust to that as well. And so the most important robustness check in my mind is this looking at people in the early 30s. And one reason is that there's this contamination with the 25-year-olds, and the other is the aging in. And so I find that this group has very similar, if you look at the event studies look very similar for STIs for the people in their late 20s, but the effects on fertility are smaller, not statistically significant. So that tells me that they also are responding in terms of their risky behaviors. It's just their biological age is affecting their fertility outcomes in another way. So some other things that we talked about were how can this policy be affecting other things that could be driving my results. So one thing I wanted to look at is, does this cause people to use more healthcare and have different STI testing? So I didn't find any evidence of STI, either policy affecting STI testing, though the data on STI testing is not very good. So I had to use a different data set that basically surveys doctors and asks them for what they did in doctor's visits and if they tested for chlamydia. And so it's not the optimal, but it's the best available information I could find. I actually find that people go to the doctor less. So it's not that people are going to the doctor more and getting more STI testing, is that I think people are going to the doctor less because if they're getting a longer acting form of contraception, they don't have to go to the doctor as often for the well visit. They can get their IUD and not go to the doctor for as long as 5-10 years. And so I actually find that if anything, doctor's visits are attenuating my results and not driving them. I also did falsification tests on demographics, looking at things like are the results correlated with these other mandates at the state level, or abortion regulations, or gender and race makeup of the state. And I found there was like one small but statistically significant result and about 20 coefficients. So it looks like it holds up pretty well to these falsification tests. So that's those results. And then let's talk about what happens when we look at the extensive margin of health insurance. So as I mentioned, starting in 2010, people in their early 20s up until their 26th birthday through their 25th year can be on their parents' health insurance if their parents' health insurance allow any dependents to be on their insurance. So a lot of companies actually let people do it earlier than September in 2010, but 2010 is what I'm calling my first post-period year. And so basically, this moved people from no insurance to having insurance. There were some people that switched insurance, but that my empirical strategy doesn't take those people who switch from one form of insurance to another into account. So what do we know about this mandate? Well, we know that it increased insured rates amongst people in the early 20s. So this is from an article by Summers et al. In Health Affairs. So in this top line, we have people who are not affected by the policy, people in their late 20s and early 30s. And in this red line, we have people who are affected by this policy, people in their early 20s. This is like consistently the highest uninsured group in the nation. And there's usually about a 6 or 7 percentage point difference between these two groups. But as soon as this policy, when it goes into effect, this group catches up and matches the control group. So they say this is about a 6.7 percentage point increase in the insured rate for this population. I think that's pretty compelling evidence that we got an exogenous shock in insured rates for this population. So let's compare the mandates, sort of disentangle what we would affect from this mandate versus the zero cost sharing mandate. So this one goes into effect earlier, and as I mentioned, it affects the extensive margin. People are moving from not being insurance to having insurance. It's pretty ambiguous, and I'm going to go into this in a second, about what we'd expect this policy to do, but basically it's going to do all these things, and it's going to do some countervailing things. The age groups for this are through the age of 25, and I'm going to look at people in their early 20s because that's what the data is available. So what do we expect? Why is there some ambiguity on the dependent coverage mandate? So this is this new extensive mandate that I'm talking about here. So as I mentioned, if you give people cheaper birth control, you expect them to use more birth control, to use fewer condoms, to have fewer unintended pregnancies, and have more STIs. This policy also, I think, would cause more people to use prescription contraception and so use fewer condoms. And so they have this decrease in unintended pregnancy, but they maybe would also have an increase in intended pregnancy. So if a person wanted to have a child, but it was prohibitively expensive, there's a lot of medical care costs associated with having a baby, then getting insurance can make having an intended pregnancy much cheaper. And so it's unclear which of these two effects will dominate. So the cheaper prescription contraception, increased condom use is going to cause decreased condom use is going to cause more STIs, but this policy is also going to cause people's sexual partners to have health insurance, and if they're going to get their STIs treated more quickly and effectively because they're insured now, then they may not contract the STI even though they're engaging in more risky behaviors. And so it's unclear ex ante which of those effects dominate. So that's just summarized down here on the bottom. So what's different in this empirical strategy? So now I'm going to be looking at people in the early 20s instead of people in the late 20s. My measure of treatment is going to be the pre-policy uninsured rate instead of the pre-policy insured rate. The intuition being that if you have a whole bunch of uninsured people in the early 20s, there's more people who could exogenously experience a shock to their insurance by getting on their parents' health insurance. Whereas if everyone was already insured, then no new people are going to get insured by this policy. I'm going to be looking at 2006 to 2012. I'm going to stop in 2012 because that's when the zero cost sharing mandate goes into effect, and I don't want to get those two effects contaminated with each other. And previously, my base year was 2011, and now it's 2009. So that year is going to mechanically be zero in my event studies. So here's the event study for log condoms. As you can see, it's increasing monotonically in the pre-period, and as soon as this policy goes into effect, it flattens out. Basically, yep.
Sorry. So the reason you're not, but you stopped before the zero cost sharing mandate. I mean, do you get a sort of similar result if instead you either use as a third difference the older folks as another difference?
So for the condoms, I can't because it's everyone isn't a condom
right. No, but I mean for
the STIs.
Yeah, that's right.
So I haven't done that. So one thing I can go back to them, but basically they sort of implicitly I'm doing that. Basically looking at the event studies for the old people in their early 20s, they go smooth through 2010. So basically there is no anything weird happening with them. So if I did a third difference, basically they wouldn't really be doing anything. So it's more of a falsification than a third difference, but yeah, I do leverage that.
Okay.
And so this is actually bigger. So if you increase the uninsured rate for people in their early 20s by a standard deviation, 3 years afterwards, you would see a 15 million decrease in condom sales. And so this is it seems like a lot of condoms to me. So now looking at births, so this was ambiguous. We didn't know what was going to happen here. And as you can see, it looks like pretty much 0. So basically it looks like there's 2 possible interpretations. So one is no one's affected by anything, and this group is just have no effect on the fertility. I think that resonates more with me is that there's 2 countervailing effects that have a net 0 effect. That there's more intended pregnancies and fewer unintended pregnancies. With the data I have, I can't really get at that though, but those are the 2 possible interpretations, and there's a very small effect on total fertility for this age group. Here's the event study for chlamydia. So again, it's pretty much increasing in the pre-period and then slopes down slightly in the post-period. And so basically, high uninsured states were having more and more cases of STIs, and when this policy went into effect, they stopped having more relative cases and started going the opposite direction. And this resulted in about 40,000 fewer cases of chlamydia 3 years after the policy went into effect. And this is the last event study. This event study looks very similar to the previous one, but since gonorrhea is less common, it's only about 15,000 fewer cases of gonorrhea in the back of the envelope calculation. So what are our takeaways? So one is, yeah.
I guess I just want to get sort of your reaction. So you're young, you're on the market using using this.
Mm-hmm.
I mean, I know it's been done before, right? Finkelstein has done some sort of version of this sort of in her work. But sort of what's the reaction to this approach of sort of controlling kind of for the pre-trend, which often is sort of non-zero if you look at it, and the post sort of trend is sort of a 0. The difference maybe in the jump and the slope is different, and that's your story about what's going on, and I get it.
Yeah.
But sort of the old folks that sort of look at this and say, "Damn, I hate the pre-trends.
Yeah.
I don't know."
The anchoring to the difference and difference assumption.
Yeah, basically.
So when I did this practice talk the first time, it wasn't even a practice talk. I did a seminar internally at my university, and I got a lot of pushback. I think that was because it's not standard, and I hadn't honed how to explain it well. I didn't.
Really good job.
Thank you. Thank you. But on the market, I actually didn't get a lot of pushback. I think because I clearly stated what the assumptions are, and if you don't buy it, then that's fine. That's true for a lot of causal inference strategies. People like, I do RCTs, and I don't like difference in difference. But I actually didn't get a lot of pushback on that. I think because a lot of them reversed trend or like had strong there was a lot of strong trends and like stop a little or kink down the opposite a little bit. Yeah. They weren't like strong reversals in trends. It wasn't like this, but it was like often like that. I think people were often compelled that there was something happening in that time. The other thing that did come up sometimes is this ex ante moral hazard because of the traditional mechanism. But this is a lesson. If you get a lot of good pushback earlier, then you know how to preemptively address it. So people on the market just say what the answer to people's question is before they have a chance to ask it. So yeah, I didn't really actually get a lot of pushback. So I do find ex ante moral hazard from health insurance. Health insurance did increase people's risky sex. But if you give people comprehensive health insurance, then you can counteract a lot of these unintended consequences, basically through this positive externality of probably people getting their STIs treated more quickly and effectively. So I think that's a sort of interesting intermediate micro lesson that one market failure can counteract another market failure, positive externalities. This is basically an ex post moral hazard counteracting this underuse of STI treatment. Yep.
So I just want to be clear why there was a big reduction in gonorrhea and chlamydia following the extension of the coverage. Mm-hmm. Is it because people went to the doctor and got tested?
I think it's that people went to the doctor and got treated. So I find that people did go to the doctor more. So even though there's fewer STI diagnoses, people are going to the doctor more. And so I think what's happening is they're going to the doctor and getting treated. So I don't actually find I don't find any real evidence of differential testing, but mostly in going to the doctor.
While I had you, I had a question about the literature. You mentioned there was a study by Gross et al. That emergency contraception did not affect fertility or abortion rates. Mm-hmm. Now, is emergency contraception a morning after pill?
Yep. And other, yeah, it's like Plan B and things like that. Yeah, it's like after. It's not it's not prevention from the sex. It's prevention from the birth.
Didn't affect either fertility or abortion. Now that contradicts common sense.
So this reminds me of a question I got in a job market talk about, like, if we expect, like as economists, we have hypotheses, and so if you show us that those hypotheses are true, then what did you contribute? And it's that, I realized later, it's that oftentimes our simple models of how people will behave don't always capture it, and we're sort of wrong often. So in terms of what we expect people to happen, how we expect people to behave, and what outcomes we expect to observe from that. And so this was sort of like an example, an exception of the overall finding in the literature that people do behave the way we think they will. But I think that there could be a lot of compensating behaviors that we maybe would expect. So if people know that they can get Plan B or emergency contraception, if they engage in this sort of ex ante moral hazard and have more unprotected sex, are they more than making up for the benefit of the prevention? So if people are having more and more unprotected sex such that unintended pregnancies increase a lot, that could cause the zero effect. Basically, they've canceled each other out. But yeah, it's a surprising. It was an example of a surprising finding in the risky sex behavior literature.
So I know from talking to Doubleday that they've received a lot of pushback on some of their ex ante moral hazard stuff, but certainly with behaviors that you might not expect, as you said, to sort of be affected as quickly, right? Like smoking and things like that. That they've found some evidence of. But how would you place the magnitudes of what you found? The magnitudes of the effects in the space of the plausible, given what else we know about ex ante moral hazard.
So I think that's an interesting question. So I think that they're meaningful, but not surprisingly large. So 1 percentage point increase. So a coefficient I have is a 0.1 basically. So a 1 percentage point increase is a 0.1% change in slope. And so as you saw from the back of the envelope calculations, that can be several thousand cases of an STI or several thousand births, but there are several hundred thousands of those outcomes. And so I think it's meaningful, but it's not shocking. I think one thing to consider is that, as you mentioned, this is maybe sort of the upper bound of the effect sizes we would expect from ex ante moral hazard. So, this is a really meaningful outcome, unintended pregnancy, and this is a behavior that results in very quick consequences, but still they're sort of moderate but meaningful sized effects. And so, but I still think that's probably like as high as you're going to find from a lot of ex ante like distortions from health insurance because of those other behaviors taking longer.
Sure. So Brad Hirschbein had that paper a few years ago it was the University of Michigan, I think, working paper where they looked at sort of the effect of a quirk in a deficit reduction act during Bush's second term that dramatically decreased the price of contraception on college campuses because it sort of removed this subsidy that was going to clinics on campuses. So this is sort of an exogenous shock in the other direction, right, to the price of contraception, and they tried to estimate the demand for condoms, sex. How does what you found sort of the magnitudes relative to what?
So I don't remember what they found exactly. So I'd have to look and get back to you on that. Yeah.
Okay. I mean that's what this sort of. I mean it's not insurance, but it reminds me of a price shock. Okay.
Yeah, because it's just a cross price elasticity.
Yeah.
So the zero cost sharing mandate, which is the main analysis I did here, is that an increase in STIs. This is the main consequence of ex ante moral hazard, and I find a decrease in births. And this is really important because there's no countervailing effects of insurance. No one else is getting the STIs treated. This is just basically this change in the cost of prescription contraception. I think a nice thing here is by focusing on risky sex and looking at two policies, I can sort of disentangle and compare the intensive and extensive margins. So what are the policy implications? I work with a lot of people in the policy analysis department, so this is really important. So one is health insurance can have these unintended consequences, but if you give people comprehensive coverage, you can counteract a lot of the consequences. So if you give people health insurance, they may be engaging in more risky sex, but they're not experiencing more STIs, so this seems like a net social increase in welfare. But what is driving this is basically you subsidize prescription contraception. People are substituting away from condoms because the relative prices are different, but the relative benefits, if they stay the same. So if you want to encourage people to use condoms, you can subsidize condoms. I was talking to someone from England, they're like, when a person goes to the National Health Service to get prescription contraception, they just give them a box of condoms. And so, removing as many barriers as you can to people using condoms is one way to counteract this. Another thing that I thought was interesting, that was a comment given to me, was that the financial cost of disease isn't the full burden here. It's very burdensome, not only financially, but in terms of health conditions and also other ways of having a sexually transmitted disease. So you directly lose utility from being sick and injured. Also, I was thinking about, you're supposed to a person's supposed to contact their previous sexual partners to tell them they have been exposed to a sexually transmitted infection. I think that people would pay a lot of money if they didn't have to do that, but one way they could prevent themselves from having to do that is to engage in more comprehensive forms of prevention. So what are some future directions? So one is actually empirically testing if removing barriers to condoms decreases STIs and increases condom use. And then actually recently someone pointed out that there's a study about this. So other plausible areas of extramural hazard contact and other contexts. So one is when statins became available, basically this chemically lowers your blood pressure. You don't have to eat as well or exercise as much to not have a high risk of cardiovascular event. Did that cause people to exercise less and have worse diet? There is actually some empirical evidence about that. I can give you the citation. I haven't added it yet if you would like to know that. And then also there's a new study, a couple of studies about Naloxone and opioid choice and opioid use, and does that affect that in a way that is unintended? So basically, are people using more opioids? So these are, I think, drug overdoses now that people have already done it. It makes a lot of sense. It's a good place to look for distortions in these kinds of behaviors because it has such quick consequences. And another thing I've talked about that people should think, I think that doesn't get as much attention is that my understanding is that when a woman gets a prescription for contraception from her doctor, the doctor talks to her about the remaining risk of STIs. Oral contraception, IUD, doesn't protect you from these risks. But as I mentioned earlier, it's at least anecdotally often the male partner who is purchasing the condoms. And so if that information is not moving, especially in non-monogamous sexual encounters between partners, then men may not be purchasing the optimal quantity of condoms. And how do we make sure information is getting to everyone who's involved in the decision-making process? And so that's the end of my presentation, and thank you for your time.
Anyone have questions? Otherwise, Barton will be around here for a few minutes before his next meeting, and you can feel free to come up.
I have a question. Did you come up with any costs related to absence due to STIs?
Labor force effect?
Yeah, because you were saying more are going to the doctor, they're being treated. But what is the cost effect in terms of absence from work? Even if they're treated, was there? So
I actually don't, that's an interesting question. I haven't looked into that, what are the foregone earnings or productivity losses from doctor's visits. So I was looking particularly at well visits, so your annual checkup. So I think another interesting thing to consider that is what are the short run cost of going to your well visit versus your long run cost of not having to go to a doctor for a more serious treatment. But I think it's interesting because even a few hours missed from work is
it's costly.
It's costly.
Yeah, the only reason why I brought that out is because you were saying one policy it's subsidizing sort of for this other policy.
Mm-hmm.
So one covers the other, but one contradicts the other.
Mm-hmm.
I was just wondering in terms of labor force how that is coming up. If there's any analysis, that would be an important point to know.
Yeah, that's an interesting point, yeah.
Because if people are being cared for medically, which is one of the statements you made, how about the ones that even though they're cared for, they have to be absent from work?
Mm-hmm. Yeah, because important non-monetary, well, I guess it's monetary, but it's not, the cost to the doc. It's not the payment to the doctor that is the, but it's the foregone earnings and project. Yeah, that's interesting. More. Yeah, I'll have to look into that.
Are there any surveys out there that ask about contraceptive use? Instead of having a look at just condom sales, if you could actually look at the individual level and see.
So Burfist used to ask about stuff like that, and they stopped in 2011 because that's not a risky behavior that needs to be surveyed, I guess. So they used to ask. Now they only closest thing in the Burfist, which is the survey that I was expecting most to find it in, is an aggregate question about HIV risk. So it asks a multi-barrel question of, do you use intravenous drugs illicitly, and do you engage in these risky sexual acts, and do you do this? And so there's not a national survey that's good for a longitudinal analysis to ask that. Something like there's the National Survey of Family Growth asks about it, but you're not supposed to use it for longitudinal analysis, nor are there public geocodes, and it's pretty small, so I don't think you could get a very good, you couldn't really do this dose response analysis with it. So no, and I don't know why, and it's very weird to me. Let me know if you stumble upon. Because I initially wanted to do microdata, but my analysis is basically the state year level anyways, because that's what the treatment intensity is. But yeah.
I mean, the YRBS asks it, but just for high school students.
Yeah.
And the LSY, do they sort of keep asking them as they age into what they must? Right?
I think they do keep asking them.
I mean, granted, you have small numbers of people in each state and sort of other rest of what you can do with it. Some people still use the LSY for doing
I think that there was some problem with I think that there is there's a tail of them. I think they're not quite the right age, or sort of slowly moving out of the correct age group as I move to later policies. And so, yeah, it's a risky behavior. Why don't we ask about it? But I guess we don't very often.
Have you found any acknowledgement after the Medicaid extension as to people addressing that STIs are on increase?
So, I don't know if anyone's looked at look at the effect of Medicaid expansion on STIs.
There's been evidence that is so plain visible to the policymakers as to the increase of STIs.
I haven't seen any policymakers. I think almost all of our fights in healthcare are sort of.
There's no literature because I'm just learning it from you.
Yeah, so I think that, I haven't seen anything. I think a lot of the political fights are more about insurance and the ACA generally, and I agree. Yeah.
All right, thank you.